Mu'nis Academy, episode number 8. From bedside to the best practice. Here is a 44 years old man presented for colonoscopy because of bleeding of rectum. You found in the sigmoid 1.5 centimeter pedunculated polyp, which is removed using a hot snare. You continue till the cecum and nothing identified more than this polyp. You send it this polyp as a pathology, and the pathology showing that it's motorly differentiated adenocarcinoma and no lymphovascular invasion. And the distance between the tumor and the cautery margin is 4 millimeter. So what's the next best management of this patient? If you will refer the patient for right hemicolectomy, left hemicolectomy, and adjacent lymph node, or you say the patient have to come back for colonoscopy after 3 months and take a biopsy for polypectomy site, or you recommend a repeat colonoscopy in 1 month, in 1 year, or in 3 years. To answer this question, you have to know that what is the high risk feature for pedunculated malignant polyp. The malignant pedunculated malignant polyp have a high risk for residual and recurrent. Which feature of this? If the pathology is saying that's a poorly differentiated adenocarcinoma, if you found a lymph node invasion or vascular invasion, if the line between the cautery line and the edge of the tumor less than 1 millimeter, it's considered positive. It should be more than 1 millimeter, which called the safety margin. Most recently زودوا من 1 مليمتر إلى 2 مليمتر، يبقى at least it's 2 millimeter, because of the pedunculated polyp have a lymphovascular channel invasion, lymphovascular channels, which may involve it in the tumor cells. Another question: what is the indication for ESD in colorectal, including which of the following? Lateral spreading through non-granular type, ولا Paris classification type 1B, ولا lateral spreading tumor granular type with uniform pattern, or Paris classification type 3. عشان نجاوب على السؤال لازم نفتكر الباريس كلاسيفيكيشن. باريس كلاسيفيكيشن تايب 1 اللي هو بلوبايد subdivided ل 1B pedunculated، او 1S اللي هو سيسايل بوليب، تايب 2 اللي هو non بلوبايد اللي هو subdivided into type 2A or B or C. 2A slightly elevated, to be completely flat, and it's very difficult to identify the edge. 2C, which has a slightly depressed area. Type 3 is excavated and should be removed, and don't try to touch this lesion. What is the management algorithm for treatment of type 2 Paris classification? First, you have to identify, is it which type? It's 2A or B or C. If it is 2A, it's carry low risk. 2B, intermediate risk. 2C, it's higher risk. Next, you ask yourself, what's nice? Is it nice 1? So it's hyperplastic peroxycyl serrated lesion, so EMR is the best. If nice 2, it's adenoma, or there is a superficial submucosal invasion, so it's either ESD or EMR according to the size of the lesion. If it's 9-3, it's depressed, so surgery is the best. If it is type 2A, EMR is a first choice, but you can shift it to ESD if the lesion more than 2 centimeter and non-granular or suspected pattern. 2B, the best is ESD, but you have to identify the margin and you have to make a sign for the margin by ABC before you start cutting, because once you start cutting, you will lose your plan. EMR only if the lesion is less than 1 centimeter. The breast ESD only in superficial invasion surgery if nice 3 or non-lifting sign تيجي ترفعه ما يترفعش أو ulcerated or deep submucosal invasion. Paris classification زي ما احنا قلنا 1B اللي هو بالبايت 1S is best treated with snare peripectomy, while type 2A is low risk, so you have to do EMR. Type 2B intermediate risk, you have to do EMR or ESD depending on the size and suspicious. Type 2C it's high risk, so doing ESD or surgery. Lateral spreading tumor, it is subtype of Paris classification. It's called paragrammatic classification. Lateral spreading tumor, this lesion is 1 centimeter with global non-bulboid morphology as a lateral spreading tumor. The term lateral spreading tumor is not used to describe as a large 1 centimeter sessile polyp. The lateral spreading tumor sub-classified into non-granular type or granular type. Non-granular type subdivided into pseudo-depressed type or flat elevated type. Granular type ya homogeneous ya mixed type. Pseudo-depressed, which less common than the flat, but it's carrying a high risk for small submucosal invasion. While the flat type, it's multifocal and submucosal invasion, it occur. The best is the granular homogeneous type, which has the lowest risk for submucosal invasion of cancer. Mixed type, it is the highest submucosal invasion and usually in large nodule if more than 1 centimeter or in the depressed portion, which is the most risky part for invasion. So what is the treatment? Treatment according to what you classified. If you see the lesion is pseudo-depressed type, non-granular, so or flat, it's carrying 40% incidence of tumor, especially pseudo-depressed. So ESD for in block and avoid piecemeal EMR because you will miss deeper invasion. Granular type, EMR is the best. You can make a piecemeal EMR acceptable for a large lesion because this is the lowest risk for recurrent and local invasion. While the mixed type, ESD or in block, the remaining area you have to do EMR and the edge you have to cut with ABC. When indicated to send surgery if nice 3, جيت ترفعه ما ترفعش, if you found ulceration with depression in the center, if deep submucosal invasion on imaging or using optics endoscopy. So the answer will be lateral spreading tumor, granular type with uniform granules. إذا كان المحتوى عجبكم نعمل لايك وشير، واهلا وسهلا باي كومنت او اي اقتراحات. الى اللقاء.